Do we have any adults people?
If you're an adult provider, please raise your hand. I guess they're not interested. So I was thinking about this, like the adult provider is not going to be interested, right? I mean, they don't have to prep them to go there.
But you know
Uh,
what? They should be, Manu. They should be
they should be.
interested.
They should be. They should be.
Uh-huh.
So I'm doing, yeah. So just to give you a little intro, so I'm Manu Cambodge. I'm at Nationwide Children's Hospital. And actually, I wasn't supposed to be kind of running this, and Todd just reached out, and we are going to have a discussion here, so I can facilitate, help facilitate. And we have an A team here. Here's Sarah too. Hey, Sarah. She's done a lot of work on this already. Our team has work going on for a while on this and still not aced it. So I think this is a good initiative. We all struggle to kind of get the perfect plan together, and there's many pieces. So I agree with this topic that just came up about the adult providers being invested in this too. So we do have an adult provider at our institution who is kind of involved, although it's challenging to get them to participate in all our meetings and things, but theoretically they are involved because there's a lot of conversation about when they see our patients who are transitioned to them. They are not happy with the skill set that those patients have. And unless they participate, we probably won't know the better, because once we send them over, then we don't have that feedback. And there are a conduit to kind of getting that feedback. So, all right. So I'm guessing, and Dawn and Nicole and Holly are going to help us through this, I guess. So how many of you have a transition program where you are? So pretty much everybody? Is there anybody who doesn't have a transition program in their place who's on the call? Okay, so that's good. That's good. So we're not starting from scratch, I guess. And can I take it for granted that all of us are interested in joining this initiative over the next year, year and a half? Yes? Okay.
We identified this as something we'd like to work on in our program, even though we have a program, like we have a transition program, but just to optimize it. So, yeah.
Hey,
okay.
Do you mind if I'm sorry, can I jump in for just a second?
Sure.
I just wanted to, so Faisal Malik, I think, was on a different group, and it looks like he's found his way to this group. And I'm not sure, but it might be helpful, Faisal, for you just to like take a step back and let people know what we know already, because Faisal had kind of pulled together like a talk that would have been given in November on this topic had there not been a hurricane. So I'm happy if you want to facilitate, feel free, but I just wanted to let you know that Faisal's on now and has some maybe some framework for us on this.
Perfect. Go ahead. That makes it easier.
Yeah, thanks.
Sure.
Thanks for the handoff, Sarah. Yeah, no, I think what's really exciting is not only to see some familiar faces on the screen, but we as a work group are probably the best position, because we've already actually been doing some work on this in this arena already. So I'm really excited that the T1D Exchange has decided, one of the things that Sarah and I have been providing feedback around is that there's a lot of smart people working on transition, and there hasn't been a formal work group to really try to learn from one another. And so it seems like this is obviously true with diabetes technology as well as diabetes distress. So I'm just excited we're doing this, and hopefully this will set us up for success. But I'll just share what Sarah has kind of hinted on. So we've already been working on understanding healthcare transition practices in the collaborative itself. So what I thought we could do is just talk about what work has been done to this point, because I think that will help us with some of the next steps that have been highlighted below, in terms of what could our deliverables be. But I think always having some preliminary data can be helpful. So what I'll share is an abstract. It looks like I can't share my screen. Nicole, would it be, or whoever's sharing the screen, would it be possible to stop? And I'm going to quickly try to share or Dawn, would that be okay? Thanks so much. So I just want to share some preliminary work that we've done within our collaborative. As you guys know, there's a lot of approaches to how best to support healthcare transition. One opportunity or one framework we can use within the collaborative is the 6 core elements of healthcare transition. And so I thought I would just share like where we are as a collaborative on this front, and then we'll open it up a little bit more to talk more about what our focus can be. So this is still a work in progress because we're going to be presenting this poster at the ADA, but I thought I would share that data so you guys can see it. Okay, so again, this is just to set up the conversation to let you guys know that where we are as a collaborative around healthcare transition. I think what's already been highlighted, it's really important, is our adult colleagues are thankfully their clinics are expanding. The key piece is how do we partner with them? And you'll see that's probably our biggest gap. So as we lead this discussion today, talking about that adult involvement is going to be important. As Nicole highlighted, Sarah's med peds trained, so she's been a great resource, but I think having more adult input is going to be important. So what we did in the annual survey last year was look at how many of the clinics had implemented the 6 core elements of healthcare transition. And really all I'm trying to highlight here is that there's room for improvement. When we had a pretty robust response rate, most of the healthcare transition questions were geared towards pediatric institutions, and we can talk about how we can better get some data around adult transition practices. But I think starting off with the 6 core elements, it's to have a policy or some kind of approach as to how you're going to support healthcare transition. How do you track the youth that require transition? And more importantly, how do you receive them? How do you assess their transition readiness? How do you support the planning from going to pediatric to adult care? And then how do you make sure that the great adult colleagues, it looks like Shivani just joined us, are in a good position to receive them and then provide them with the care, and that there's a closed loop saying, hey, that emerging adult or that young adult has made it to my practice. So what I'll just highlight is that we asked each of the centers about where they were on these 6 core elements, because this can drive what our deliverables can be or what change packages we might work to create. And what you can see is that, less than 40% of pediatric institutions said they had a policy around healthcare transition. Less than half said they tracked youth that were requiring transition. This is a big piece that we can definitely support is how do you assess healthcare transition readiness? You can see that only about 40% of pediatric diabetes centers said they were doing that actively right now. A little over half said they were documenting a plan of care. Very few were providing a transfer package to assist in that transition to adult care. And then this is probably the hardest piece because it requires a partnership between pediatric and adult centers and adult practices. And you can see that only 28% said they had a process in place to confirm transfer of care completion. So I'm highlighting that more that our group, our collaborative is, there's certain things that we're just excelling at. Transition is one where there's a lot of room to improve. And this is just the pediatric perspective. Again, I think in the adult side, we'll probably see similar results and different challenges, and we'll have to work through it. So before we kind of go into the back to Dawn's slide, I just wanted to open it up to see if people had any additional questions about some of the early data we've already collected within the collaborative that I could shed more light on before we talk more about what the work group could focus on. Any questions about that data?
I just want to jump in and put one important nuance out there, that this is really about a very young person who is coming through care from ped side to adult side. And so with our expectations, I just want to keep that as a frame of reference, that this should not be punitive in any way, that, kids should feel excited about this transition. They should be excited to leave pediatrics and excited to be received at adult care. And it really is an individual timeline. So not every kid is going to be ready at the magical age of 18. Some might require a little bit extra time because their lives are becoming full and they're transitioning to work, to service, to college, all these different avenues. And and you have to meet your patient where they are. So just a couple points as a mom who's put one through this process, one who is not quite ready at 19, but will be going through this process. I just want to keep that in mind.
Amy, I
Thank-
appreciate that comment. I mean, I think there's a structure of how do we create an infrastructure to support successful transition, but how you tailor that care and how you meet that emerging adult's needs are obviously going to be tailored to that individual, and it's going to look different. And I'm glad you brought that up. This isn't one of those pieces where you can say, hey, everyone's going to have the same roadmap. They're not. I think a lot of it depends on where they are in their own journey to independence, what else they're navigating, whether it's college or work. There's a lot of transitions. So yeah, I think you need to look at it comprehensively. And as we think about outcomes, we'll have to think about what is an appropriate outcome. But I think the big piece is at least having a structure in place to say, how do we support them in that process so they're not lost? Because that's something we can support them with. So thanks for that comment.
Amy, thanks. I always love your perspective, and I think it ties in nicely with the focus on language from before. And I do think that there's some negative connotations to leaving pediatric care. We hear like, are you kicking us out? Or, like lots of things like this. And so in our language and our policies and our procedures and in our readiness, we really tried to emphasize sort of developmental readiness, and when you're ready to graduate pediatrics and move on to adult care. It's like, again, it is not a punishment, it's not pejorative, it's not bad, it's not like adult care is worse, or it's like, I just think there's a lot of layers to this. So I just think, again, it's kind of a thing to be celebrated. It's like, you've made it through your adolescent time with diabetes, you're like, you've accomplished all these life skills, you're ready to move on to the, so I just think that that concept of readiness and a sense of accomplishment, right? Like it's a capstone. You've moved forward in a predictable, in a successful way. So how do we kind of, again, carry those themes of the power of language into what we do as health system and as practitioners? So appreciate that comment.
I would like to bring one thing into perspective that I think differs from state to state. I practice in Oregon, and one of the huge challenges that we have is access to adult endocrinologists around the state. So Portland is really at the border with Washington State, and it's very far from some of the population centers. I mean, 200-300 miles. And we have actually created a really lovely program for young adults. We have the Young Adult Diabetes Clinic that is staffed by a very similar team as we had in pediatrics, and we worked with our adult colleagues because we're under the same roof and created that program, and we actively collaborate. So it's really, exactly, Amy, that comment that we shouldn't be punitive, that was a big North Star. Like you're just kind of moving to a place that's very similar to where you were, and they have groups, meetups, and they have social component, etc. However, there are young adults that followed in our pediatric practice because we had outreach clinics, and we do have still outreach clinics and outreach telehealth, and we would go to places like Eugene and Medford and Bend, which are far from Portland. However, when these young people want to stay and follow somewhere locally, I get replies from local endocrinologists that they are just not accepting any new patients. So that becomes challenging because our adult service does not have that kind of outreach, and I think that that's a big thing that we have to take into consideration. And again, each state is going to be different, but when thinking about something that is universal and improving the process, we have to take that into consideration. Because you can have the best process there is, but if you don't have anyone to hand the patient off to, it's not going to work out.
I agree, and I don't think that problem is limited to just a location. It could be within the center as well. So what we're experiencing at Michigan right now is that we have patients who are ready to transition, and there is no adult provider that's, excited to receive these patients because they have a full roster of patient care already. We don't have enough providers really, in essence, to, accept all these other patients that are coming along. So what ends up happening in the case of our family was that we had to find the right provider. We were given a open slate. You could go anywhere. And it was even suggested to leave the community that we had been in because there was a possibility you would get easier access to other physicians outside of the network. And that's unfortunate. Like I don't want to see that happen, but that is a reality. We stayed, we were lucky, we were able to go in to see another adult provider. And now what's happening is, that the families that you've kind of grown up with in this process, so they will all ask, what provider did you go to? And that causes even more stress and strain on the provider that did accept, the family, because now they've got a request from 20 other families and they all want to go to this provider because that's the easier pathway in finding the right adult care. Doesn't mean that that's the best process. So I agree. I think we need to do something about that, which is why an adult side really does need to be present to kind of talk about some of this. And then one other quick little thought that I had, that knowledge base. I mean, I raised a 3-year-old up into transition, and all of that was lost in adult care. So when we went to that adult patient, even in the network we were in, she was asked questions that were so foreign because, she was brought up in this process and it was like starting all over again. It was like she just was diagnosed with diabetes. And that's really unfortunate too, because here she is trying to assert herself and becoming an adult. And there was no acknowledgement of the years previous leading up to this that got her to where she is today. And that first appointment was kind of rocky just for that sake of, oh my gosh, you don't even know who I am or what I do, or, what kind of person I am or how I've taken care of myself. It was, is your blood sugar in good control kind of questions, and this is a high achiever, somebody who really has had good success with her care growing up, and it was all lost. So I would love to see that kind of implemented as something that can be supported.
Dr. Rahman, we see your hand. Would you like to share next?
Yes, thank you. I just had a question. So I'm Vana Raman. I'm at the University of Utah in Primary Children's Intermountain Healthcare. In the poster that was shared, was that the survey that was used? Was it the gut transition survey? I know at Cincinnati, there's a READY survey that's being used. So I'd love to learn more. And I'll tell you where we are at our institution. So this is a big pain point, a big thorn on the side for several of us. I think we can do a lot better in our overall transition program. And that's a big focus for us this year. I'm excited. We have a MedPeds fellow joining us for a 4-year fellowship. So really excited about that, and to get a formal transition program started. We did use the gut transition survey and have collected information. But I think we might pivot to the READY survey and I'd love to learn more. So excited to be part of this working group.
If I can speak, go ahead.
Yeah, I just wanted to share that I think that what those were our attempt to just share that there's opportunities for us to see where we are, and some of us are doing different elements and some are not. So Vana, to that question, we'll share what those survey results are with this whole group, even if you weren't part of that preliminary data collection. And I think all we're going to try to do is try to understand where all the different centers are, particularly those who are involved in this work group, of incorporating those 6 core elements so that we can learn from each other. So for example, if you want to say, hey, I want to do readiness assessment, how can that be done? I do want to transition to going back to Dawn's slide, but go ahead, Shivani, of trying to think about how to set up this.
I'm just wondering, am I the only adult center here? Okay. So I think this is representative of the field, obviously, the natural state of things. I'm not MedPeds, but I just decided to have kind of a pet topic. So My imploring you on this is to make one of your QI goals to actually curate an adult team. Whether they're in adult endocrine or primary care, you may have to swallow a pill, but it's still going to be better than no care. And I see tons and tons of young adults that float through the ER to me. So that was really what I had to say, is I would love to take all of your young adults across the country, but until telemedicine licenses become national, I can't. And so if that can be part of whatever QI project is developed, developing an adult team is like easier said than done, but I can give you guys, even if I'm not, I don't necessarily know if it makes sense for one adult site and then lots of ped sites to be part of this QI project, but I can even just help like consult to say, this is how you talk to and curate adult groups of providers. And I'm happy to lend a hand on that because yes, the alignment of goals of care and priorities from peds and adult like have nothing to do with each other. And I think that's the crux here is that disconnect.
Shivani, I have a follow-up question for you. When you say adult teams, do you mean at each clinic or a single adult team that kind of can parallel this group so that there are counterparts?
I mean, so because this is going to be QI within site, right? Like each site kind of needs, and if every ped site is going to be doing transition initiatives, they have to curate some adult team to receive their patients at their own site, right? It is now becoming, unfortunately, a part of your transition readiness is actually infrastructure. You have to build infrastructure and pathways. It's a different way to think about just the patient, right? But you actually have to build the pathway and the track. So how to do that, it's easier said than done, right? I'm sure a lot of adult endos are being like, no, I don't want to take that patient. Right. I get it. I totally get it. That's why we have our program. But I'm just wondering if there's a way, maybe a unique way to do this is to find any of your adult providers to like, come talk to me, not just run focus groups with them. I don't know. I'm just thinking outside the box here, but trying to figure out how to make this a QI project, while really impacting outcomes may have to involve curating some sort of adult receivership team, however that happens.
So some of these pediatricians have, like Risa, you have your counterparts on the adult side because you're a hospital with both pediatric and adult. And as the same thing for the children's hospitals, do you feel like you have that same thing because there is an adult endocrine facility within your geographic boundary, even if they're not tied directly to your children's hospital?
Excuse me. This is Sihem. I'm sorry. I don't know how to put up my hand on the computer. So I just want to say, besides, we do have actually, just to answer your question, but I have another question to ask as well. We do have actually an adult endocrinology group that we refer our patient, but they a lot of time our patient don't feel comfortable, especially at 18 or 19 when they are just going to this huge transition, and as the previous speaker was talking about, depend of the area that you live. We live in New York, and all of the kids are going to college, so they are going to be leaving. A lot of them wants to go out of state, so that's going to be even a bigger changes in their life to have to deal with a new physician that they don't know, or a new care team that they have no how do you call it, a real connection, the type of connection that they have developed within years and years with their pediatric teams. So that in our practice, actually, we accept. I mean, if somebody want to leave earlier, that's fine. But most of our patients transition at the end year of college or when they finish their, their college time. So I was interested actually in the tracking and monitoring, because we are trying to do the transition program, but we don't know how to track that. This piece, how do you put it in place? if you can help me with that, that would be, I would very appreciate it.
Maybe that's a QI project in and of itself,
Yes.
right?
Yeah.
Developing, tracking and monitoring, because there's so many
Absolutely.
pieces to this. Is there's not going to be an appropriate age for anyone. It shouldn't be that way. Some institutions have policies, like ours is like 22 and you're out. That's actually, that was at CHOP too, by the way, but I'm at CHAM now in Montefiore. So I don't know if even just getting a natural state of people's institutions and maybe general age of transition, and if there's an institutional cutoff policy, might be part of that step. But yeah, tracking and monitoring could be another.
So we've been doing like all the different pieces of the transition, but we haven't been doing the tracking part because you sort of need somebody to do that, and that takes somebody's time and effort. In some places where people have published on using a transition coordinator, but you have to have funding for that. So we just started this tracking process, and we assigned one nurse now that we're almost fully staffed to do it. But it does mean that like every provider has to message for like, this patient is going to be transitioning. They're going to be scheduling this time. Can you please follow up in 3 months to make sure that they actually got to adults? And we tell them who, we always identify the specific adult provider, but making sure that they get there. But like, that's like a person's, like, it's part of her job. So, I mean, you need to like have obviously the resources to do so, but I think it's an important part because if they don't ever get there, then they're lost.
Within institution, and sorry, I'm going to stop talking. For those of you that have within institution transition programs, something that we did was we developed, so we have, I guess we're mostly on Epic, all of us, because we're T1D Exchange, but we actually have a transition, maybe not some, but we have a transition template. That's an Epic built template, but we did not have IT build it because it would have taken forever. So we had our PEDS team help us make it. It's a really simple smart phrase, but have the PEDS team fill it out. And then the reason for call of that telephone encounter is like, I don't remember, it says like diabetes transition or PEDS to adult diabetes transition or something that like every PEDS provider is doing, which is amazing in and of itself. But then it doesn't have to get routed to someone to then get routed. It lives in the IT as a note. Sorry, it lives in the chart as like its own note. And so then IT can just pull that telephone encounter with that reason for call. And then we've seen everyone that at least was like referred. So I don't know if that's something you can do. I'm happy to share that, but it's been pretty successful at our institution.
I would appreciate that if you could share that.
Sure.
So I think what we're already starting to do is there are some things that we can learn from one another, and there hasn't been a resource around transition that's comprehensive at looking at all of these elements, different ideas that have been implemented so that we can learn from one another and execute what we feel is feasible given our own environment. So I think that's coming out clear that that'll be a charge. And some of it might just be first summarizing what we're all doing. Because there's so many pieces to this that we can actually operationalize and say, hey, for this, what do you do? For this, what do you do? And I think one goal we can have within this work group is thinking about what that summary table can look like for those who are trying to start working on transition, already engaged in it, to see what's possible. And then back to this point of like having these conversations with Shivani and say, hey, how did you partner with an adult? I'm trying to do it, or others. So I think this is really exciting, and I think it's all coming through. So I think we have the right group in place. Probably, again, one piece that's missing that we said at the beginning of the call is the adult perspective is something that I think we should nurture within the collaborative and bring more people in, even if they're not engaged in healthcare transition right now, because just having their perspectives will be important. So with that, we'll go ahead and get started. Dawn, do you want to get us share what the goals of this work group is? And Sarah, I know you and I had kind of planned that talk together last November. I'd love to hear if there's additional thoughts you have as we try to think about what our deliverables and aims might be.
I'm sorry, can I ask one question, Faisal? You just brought up something regarding adults getting to the project. Did you mean even if they were not part of the collaborative, but like this group, but like let's say I find one of the adult people who agree to help, can I bring him in or her?
That's what That's what I meant. Yeah, like, do you have a relationship already?
Okay, even if they are not, because my the adult practice here is not part of the collaborative, but maybe I can find.
To me, that's like part of your team. It's become part of your QI team, you know? They're actually like your other half in this.
Yeah, definitely, yes, but
So it's almost like thinking about it that way, you know, like
Okay.
not as a site. I don't know. That's how I think of it, but.
Yeah, so thanks Faisal and Shivani and everybody. I think just other comments as we look at sort of this slide and how to move from the conversation to this. Vanna, I just wanted to make sure your question got answered. The READY is a transition readiness assessment tool. So again, it was co-developed between folks at Cincinnati and Seattle, which is why Faisal and I are so familiar with it. And it's part of, if you look at that GOT transition sort of 6 steps, it's like the transition preparation step, right? It's like maybe it is a tool that you might do as part of that larger framework. And then the survey that was part of the ADA, will be part of the ADA poster that Faisal shared, went to, I think, 53 sites in the collaborative, was really just how many people are doing step 1 of GOT transition, step 2, step 3, you know, through 6. So GOT transition can be used as it has sort of a scoring strategy in terms of your maturity in that model for QI. So you can sort of say, you know, if you're starting from complete scratch, the first thing you do is the policy, right? Which is step 1. And then the next thing you do is this. So, and then tracking, which has come up is again, one of those core elements. So I just wanted to be sure we were clear on that. So the READY is a tool for readiness assessment that many of us have used. TRACK is probably the other really familiar one that's a general transition measure, but it falls kind of within that framework. So I think this is what we're being asked to do, is make a theoretical example. I know the slides just were moving.
Yeah, I think this is what we're gonna, if you go one slide before, Don, would that be okay, just to go through what we have to do? And then. I think just the slide prior has the.
Yeah, I think it was the earlier one was a little more general, was.
Perfect. Yep.
Yeah. Oh. It's hard to get just right. So again, I think if we just maybe move like to number 3 for just a moment, the deliverables, the SMART aims, the timelines, again, this is where we can spend some time talking, but I think our purpose in sharing some of that preliminary data that we have from surveying sites is that we have some baseline potential measures to think about with regard to how sites in the collaborative are currently performing. So we could certainly use that, and again, we could use completion of transition readiness or completion of transition plan as a measure. We could develop a different kind of measure. Again, we want to make this something that people can, that's something recorded and so forth. I also think that what this conversation is sharing is that there's some just standardization of best practices that also might be useful to be shared. So I don't know, Faisal, if you want to narrow that a little bit more, I'll leave it to you or others on the call.
Yeah, why don't we talk about, just so we get to hear, I don't think we've heard from Grace so far and a couple others. So just in terms of, we've talked about one deliverable, and again, some of these can be very quality improvement where we have a SMART aim. I think another deliverable for this work group is to be a resource. So I think we've covered that piece. I think regardless of, I think what we can do is shift towards that SMART aims. Like, what are some things that perhaps people could consider as being quality improvement projects that we could co-develop as a work group and perhaps launch collaborative wide. So again, one deliverable is we'll definitely explore current practices. I think what we're thinking is, maybe if this is okay, we'll first do it within our own work group and then take that structure that we feel like is very easy to follow and understand, and then ask other clinics to add to that as well. But yeah, Grace, I don't know if you had some additional thoughts on what you would hope that this group would be able to generate.
Yeah. So we have we do have a bit of a transition clinic that's run by one of our adult providers and the adult endocrine fellowship. And it's pretty cool, but it's not quite big enough for all our patients. It's also only on like a certain day of the week. So then there's patients that just can't make it to that appointment, or they don't like coming to that location. So there's like different reasons why not everybody gets through it. They use the track questionnaire in their program, and it works really well, but we need some way to kind of get it out to more people in the clinic. And so some things that I think we need to focus on in our clinic is getting more people to do the like readiness questionnaire, to start talking about transition sooner. So it's not like springing it on them like, oh yeah, you turn 18 and you should get out of here. Or like, okay, I guess we can like watch you one more year, and then when you're 19, you have to leave, and it like, they're not ready. So I want to have more preparation and more of those readiness questionnaire. And then figuring out how to make sure that they actually get that appointment. Because we do a lot of these, like, we're going to send a referral and then we'll schedule one more appointment, and then they come back and then they miss that appointment, or then you never know, like, if they actually saw the person. And I saw other people commenting on that. So I feel like some good things is sort of the prep, and then that's where I'm sort of like, I guess on either end, making sure they actually make it. And I don't know how measurable that's ever going to be, of like confirming that they made it to the adult side. And I guess that's where really, we have a connection with one of the adult clinics in our area, but they can't accept all our patients. And so maybe like Shivani's saying, maybe it is about just like finding connections so that we can, I don't know, get a better system. Or maybe if we all put our heads together, we'll figure out a better way to make a system of being able to track that. Because as far as the SMART aims go, I think it'll be really easy to track if we're like doing those questionnaires and stuff, and that's fine, but how to make sure they actually make it. I don't have the answers right now, but I think that would be an important thing to look at.
So Grace, I've definitely heard other centers talk about warm handoffs where they actually have the adult and pediatrician together seeing the patient, and sometimes one is virtual and the other's in person, or sometimes they're both in person. For in person, you would have to have your campuses right close together. Virtual, I would assume, is easier, but time is always precious. Anybody on the call do that now? Have a virtual meeting with both adult and peds for a transition meeting or visit?
So Nicole, we don't have a virtual. We actually have our adult provider come to our pediatric clinic 1 day a week. So the transition patients get seen by her for that 1, 2, or 3 clinic sessions, and then further decisions are made whether, so she's saturated now. We've done that for several years, so she can't take them anymore. So she has to actually try to pass them on to some of her colleagues. I guess the conversation is, you live 2 hours away. How do we do that? Or who's the other person who can do it?
That's our problem, Manu, because like I said, we have an adult provider that comes with her fellows twice a month. And that's actually, maybe she comes 3 times a month now. She's been expanding, but it's still not enough. And then we have patients that they're okay driving for pediatric care, but they don't want to keep driving forever. So they don't want to stay here. They don't want to keep coming to Memphis.
And that's the common theme too. For some reason, they do come for pediatric care, like 2 or 3 from 2 or 3 hours away. But for the adult part, they're not ready to do that.
Now we have, as far as the process goes, our young adult clinic is run virtually, and I think they're now going back to in person. But the process is, when they take any new patients, is they have this group meeting with various members of the teams, and pediatric providers are always welcome to join. So it's like adult providers, behavioral specialists, peds provider, patients, and it's kind of a informal intro. Hey, here we are. You're moving to this other part of our center, and here are some of the people you knew from before, and the new people you're going to be working with. But again, it is not something that all our patients will take up on, and we have that challenge of lack of community resources.
So in our center, basically, we have kind of the similar process, but it's the pediatric group. Actually, one of the nurse educator goes and at the visit that is scheduled with the adult, she shows up at the same time and stay there for 10 minutes to introduce the patient and go over everything. So to avoid, like having this misconception of if the patient is not taking care of him or herself, or basically giving the information, the basic information needed, and make the patient feel a little bit more comfortable with the newcomer, the new caretaker. But it's done in person because we are lucky enough to be in the same building, even in the same floor, and we have a transition room that they meet. But I think even if it was on WebEx, or on online, that would work. That would be something to consider. The introduction, the breaking the glass, and the making patient understand. Our problem is that, are they going to continue this follow-up after this first visit? Because this first visit is always with one of our educators, but we don't know if they are going to come back.
So this is a great conversation. Go ahead, Shivani.
No, it's okay. Where's our charge? Like, when do we have to be back in the group visit?
So, yeah,
15 minutes.
So we're gonna break at 3 o'clock, and just to remind the group of what we still have to answer for questions. You don't have to we don't have to do all the details of designing interventions now. Would it be helpful to say who will lead this group, like who is willing and wishes to be a leader for this? And then to think about the practicalities of how often this group would like to meet together. Do you want to meet every other month, or once a month, or more frequently? And then if there is time to talk about, deliverables, like an aim and a timeline, that would be helpful.
I guess if we need one adult, that's me, right? I have to be that person.
Well, I appreciate Laura's suggestion. Yeah, I'm happy just because of the fact that we've already done some of this survey work, and I've been thinking about how best to think about doing healthcare transition, both at the center level, but what's exciting is thinking about at the collaborative level, because I think there's a couple ways we could think about doing quality improvement in that way. So I think that works. And I like the cadence of a monthly because of the fact that if we're going to in November have like an actual report out, there's a lot of things to kind of work through of many things that people have been taking notes, but I think to summarize and make sure we have key things that we can really want November to be a meeting where those who weren't part of this work group get to attend and have a good understanding of where the work is and really have clear ideas as to what quality improvement projects people can relate it. So I'd be happy to be the pediatric representative. Sarah, I know you've been working really closely with me on this to this point. I don't know if you have some.
I was just trying to type in the chat, but I'll say I was typing co-lead, and then I was like, well, if it's Shivani and Faisal, maybe it's like the tri-leader. I don't know. Tricycle. I don't know. I'll be happy to stretch my MedPeds arms to a bunch of people in this space and join you guys as a musketeer in this work. I'm a big fan of distributive leadership when people are really busy and we still want projects to move forward. So happy to help out with that. And I think monthly cadence makes sense.
I agree. I thought you guys, I thought we'd just skip that part because obviously Sarah and Faisal were going to be a big part, and Shivani has to because she's the only adult here. So it's to me.
Grace, you have such faith in us. That's so kind.
But seriously, this will be pretty collaborative, obviously. But I do think actually just speaking for the adult representative, it would actually be kind of special. Siham, I think you mentioned this, if there is a way to bring in your adults providers on your team. And it's realizing, I mean, I realized too, like I could bring my peds, I could bring peds representation from my institution on my team. I actually think that would make this a little bit more unique and really special, because we'll make real change at our center levels if that's the case, instead of, you know, speaking in our silos, which we're like so sick of, right?
Yeah.
So Shivani, our adult providers comes to that clinic. We try to meet once a month or maybe even more at times for this QI project for transition. She's never been able to attend because of her. Yeah, so I think there's emails or something, participation, but then she's not been able to, just the timing of things.
Right.
So maybe the input can be transmitted on these calls, and maybe we can make them aware that, hey, we are now officially a part of the T1D transition group, and you know.
Right. And like,
yeah.
you know, there is always leadership. There has to be some leadership buy-in, I will tell you, from the adult side, because it's not a money-making business, right? So like to even open a transition clinic on the adult side, you need some sort of buy-in. And so part of that buy-in could be, hey, like now we're part of this collaborative. You need to give me an hour off of my clinic so I can make this call or something. I don't know what it is, but there are
the
ways.
buy-in is money. So we lease that adult provider's time, we pay for it. So as they're getting saturated, I may have to go up to, you know, 2 clinic sessions a week or something to get more time, but it's a money thing.
Yeah, I mean, that's the other thing quickly, but then I can talk with your adult colleagues, is the way that we've grown. I mean, we've grown a lot. You know, it was just me. Now we have 5 providers. We see 500 young adults with type 1 diabetes in our clinic. And the way to do it is the business case. It's like, okay, well, in the beginning, yeah, it's a money loser, but now we're actually preventing ER visits, right? We're like medicine and peds, all these academic centers want to see departments interact, taking all these patients and actually bringing in new patients, right, that otherwise wouldn't have been brought in. Like, these are all the things we told our leadership. So I can like talk to any adult providers that feel like they don't have the business case. I don't know. Anyway.
So Nicole, it sounds like we've got, so Shivani and Sarah, I'm excited to work with you. Obviously, this is going to be a group effort. We'll just try to make sure that we're meeting the milestones and meet outside of this, so those monthly meetings feel productive with a very clear agenda. And in terms of the deliverables, what I'm keep hearing from the group, and Dawn, I apologize. I know I asked you to share your screen and then stop your screen. Would you mind stopping your screen? I'm just going to share my screen one more time. Thanks so much. So I think what was really good is that without us really talking about what the 6 core elements were, everyone talked about how they're doing it or what they want to work on. So I think what I'll walk away from this conversation is that Sarah, Shivani, and I can try to think about these 6 core elements. But for example, developing a policy, I mean, it's awesome that Amy's a part of this, of just like, how do you outline how you're going to support an emerging adult and what that looks like? So like these kinds of elements, especially step 1, which is one we oftentimes skip, is probably the most important, because this is where you get stakeholder input and they're like, hey, this is how our messaging is going to be, and this is how we're going to support you in the pediatric side, and what our adult partners look like, really having clear outline of like what this guide is going to be for the caregiver and the emerging adult is really huge. I think we heard people talking about, I don't know how best to track. There was different readiness tools we've talked about. Then there was the planning, and then other people talk about, I don't know how to think about whether they made it or not, and whether they continue at that adult care. There are elements on the pediatric and adult side related to each of these pieces. It's a shared project to support this the successful transition. And I think there are ways for us to operationalize this. So what was really encouraging for me was to hear that a lot of people brought up pain points around each of these areas. So what we'll try to do at the next, and then again, we have some preliminary data to highlight that not everyone's doing these 6 elements, but this might be a decent roadmap to at least help us understand what are some potential quality improvement projects. And then ultimately it comes down to what are some metrics that can actually be tracked, that's feasible. And even if all 6 of these are important, maybe only certain ones can actually be tracked. But I think the other piece that we can do is not only think about what's happening at the individual center, but also what's happening at the larger group. So we'll try to put some of this together and lead some of that conversation. But I think the deliverables are like, how do we incorporate these elements? Because all of them are important. I think the question is, how do you do it? Go ahead, Dawn, sorry.
Thank you. I just wanted to remind the group that we are tracking this as part of the measures that we put on the smart sheet. And there's always questions about exactly what does that definition mean, and does it fit what we're doing, and is it one that's meaningful, et cetera. So we really should be sure that we're coming to common ground and understanding on what's already being done, and see if there's anything that needs to be expanded or adjusted off of that. Might be helpful too. Thank you.
But just a point of clarification, when I was saying tracking, I didn't mean tracking the transition stuff. I meant completion of the transition. Like, we've referred them, they're gone. We don't know if they went and really saw the provider. We tried to do it manually for a while. We had a social worker who was very interested. For a few years, she kept actually calling the family and finding out and trying to track that way. But that was no longer feasible, making all those calls and missed calls and stuff. So that piece, just to close the loop, is the challenging part.
Yeah, but I think you're speaking to the last element, which is transfer completion. It's not only did they make it, but did you confirm they made it? So thanks for bringing that up.
And then how long do you want to follow
Right.
up?
So that's actually, yeah, that's my point. Actually, I was going to, sorry, I didn't mean to cut you off. Sorry.
No, I'm done.
Okay. That was my point, is that I've always had issues with the GOT transition timeline, which is like sacrilege. You can't say that, right? But it's all from a PEDS perspective. Like, just because what did they transition? For me, it's like, it's not actually my first appointment. It's, are they retained in care? Are they actually seeing me? Did I lose them? Did they have hospitalizations that first year of transfer? Are their A1Cs bending at all? Probably not. But like, none of that is in there. Right. So I think we actually have to extend it to like a 7 and an 8. Yeah. So core elements is ongoing care.
Yeah, I think that's the piece. You're right. That's been feedback that's been incorporated. So there's more now of like those 6 core elements. Instead of viewing it from the pediatric perspective, what are those in the adult perspective?
Yeah.
And they look a little bit different. You're right. On the pediatric side, it's completion, but on the adult side, it's actually, are they getting the ongoing care they need? So you're right. I'll say that there's been a little bit more of a movement. And again, we're putting together a review paper that is going to talk about how do you incorporate these 6 core elements in diabetes practice. But you're right, Shivani. And I think some of that is just us revisiting how we talk about the 6 core elements. And it's not just the pediatric care, but it's also adult care.
Okay. Yeah. Thank you. That'd be great.
And we can work through that together.
Yeah.
As to how best to do it.
Yeah. And maybe it's like for 6 months, a year, it kind of depends on the project timeline, but definitely not the first month or 2.
Yeah. But again, we can, as a collaborative, what this group does really well is curate best practices, and like the curation of the best practices doesn't have to be the smart aim, right? You can do both. You can sort of say, okay, we're going to focus a project around a particular aspect of this really challenging problem that we're all trying to solve. But in so doing, we're also going to say, what are the best practices? And again, we can lead the field by saying, here's what's missing. And I totally agree, Shivani, because those, I've talked about this. And those are some of the outcomes we looked at for adult care too, was retention and care and so on and so forth. So I think that's, even if that, maybe if we're not mature enough to make that a smart aim, because people just don't have the capacity to do it yet, it shouldn't prevent us from putting a stake in the ground and still saying, as leaders in the field, this is best practice and this is where people should be heading. So I think we can probably do both. I think we can like describe what exists, describe the gaps to the extent that there are resources, describe them, and then also say, based on all of that, we've selected to dedicate some QI effort in this particular space.
Shivani, I had a just quick question regarding follow-up of patient. In pediatric, we see our patient every 2 to 3 months. our system is set up the way that the physician sees them, like, for example, every 4 to 6 months, and the educator again every 4 to 6 months in between. So, but in adults, as they get older, actually, it becomes 6 months. So basically, they see me every 6 months, and they see the educator in between every 6 months. But how is the adult practice working?
We've always done every 3 months in adult care, you know, regardless. If the A1C is really controlled, low, whatever you want to call it, in target range, whatever the right term is, then we can say, you know, 6 months. But even for our elderly and for our middle age, I mean, it's pretty much standard of care to see everyone every 3 months. Whether they make it to that appointment is like totally different. But we're still writing, you know, Q3 months in our notes and saying, come back in 3 months. And it could be us as MDs, it could be our nurse practitioners or PAs.
But the other challenge, I don't know if how many of you are facing that. You can technically paper sus every 3 months. It's printed there, but there's no appointments, and your next appointment may be 5 months, really.
Right. And that's just care. Or you could have an appointment in 3 months, and they don't make it, and then they're calling
Push
you
back 3
trying to get
months.
an appointment, but then you don't have another appointment for 3 months. So it's 6 months. So, you know, that is left to the attendance gods. But
Stefani, and that's exactly why you need to know who that patient was when they come over to adult care, because they're not all the same. Not every young person, 20-year-old, 19-year-old, 18-year-old, is out of control, not managing their diabetes. And again, not every young person has, you know, put that time and effort into helping their diabetes the best they can. So you just have to know, but that medicine has to be personalized completely. And that's somewhere it needs to go in the change packet, that we keep that knowledge base, and that's what gets moved over.
Mm-hmm. Well, I'm excited to work with you guys, because there's a lot of things we're also trying on the adult side that I would love feedback from for you guys.
So I know we're at the last minute. I was hoping to get Laura's input, but Laura, feel free in the breakout to chime in of things that you agree with or disagree with. So Nicole, do you feel like we have everything we need as a work?
I think we have the foundations. You know, we don't have a specific aim, but we can say that, you know, we've talked about the broad goal, and the specificity of a SMART aim, you know, is something that we can come to agreement maybe in the next meeting, or, you know, can't do it all in 1 hour meeting. I think this is really good. Thank you all for representing your clinics. I love hearing all of your feedback and knowing what's happening in your clinics. I especially love the idea of bridging with your, you know, your adult partners, so that you're not doing it all alone. Like, you're not just kind of leading kids to a cliff, but you're actually making a bridge for them. So thank you, everybody.
Yeah, and if you do have patient questions, you know, I have access to the girls. I can share their emails. We can all work together. They're used to the same kind of work. So don't feel hesitant at all to ask any question.
All
right, let's all head back to the main session.
See you on the other side.